everyone. Welcome to this webinar organized by the International Academy of Human Reproduction. Our chair today will be Professor Joseph Schenker. Professor Joseph Schenker is President of the International Academy of Human Reproduction, Professor of Obstetrics and Gynecology at the Hebrew University of Jerusalem, Chairman of the Department of Obstetrics and Gynecology at the Hadassah University Hospital in Jerusalem. His research was involved in experimental and clinical studies in the endocrinology of human reproduction, development of methods for contraception, and development of technologies in practice of assisted reproduction. He is interested in ethical aspects of reproduction, gynecological and obstetric practice, and has chaired the ethical committee of IFFS and the FIGO committee for the study of ethical aspects on human reproduction.
Hello, everyone around the world. I am pleased to welcome you to the webinar of the International Academy of Human Reproduction. This webinar of our academy will bring interesting insights for our fellows and a large audience who are following our activities. Next slide. The webinar is hosted by the International Academy of Human Reproduction, which was established in 1974 and is a professional voice for researchers in this area from clinical medicine, biological sciences, medical education, and population sciences. The Academy holds its congresses every 2 years, publishes a series of books on reproductive medicine for clinical practice, and promotes exchange among scientists around the world. Our fellows are selected based on singular and significant contribution to the field. They come from all 5 continents. Our program for 2021 is to hold a 19th World Congress of Academy of Human Reproduction, which we hope we will be able to make it in Jerusalem, Israel, 2021. We have another Congress in Latin America, in Colombia, at the spring of 2021. Meantime, since our education program needs to continue, we develop the programs of webinars. The first one was of the development of vaccines against COVID-19, which was presented by the Israeli group developing this issue, the Biological Institute in Israel. The second one was on reproductive surgery in 2020. Next one. Next slide. The present topic is progesterone, the nature's choice for pregnancy and endometrial protections. The 3 main speakers will be Giancarlo Di Renzo from Italy, Andrea Genazzani from Italy, and Martin Birkhaeuser from Sweden. The webinar was supported by an unrestricted education and grant from Basis Healthcare. Basis Healthcare had no role in the selection of topics, selection of speakers, and did not interfere with the choice of content of speakers' presentation. Progesterone has a central role for reproduction. In ovulation, regulation of uterine function during menstrual cycle by control of cyclic changes in proliferation and deturbulation. In implantation, progesterone is essential for the development of the residual tissue for facilitating implantation. In pregnancy, progesterone is essential for maintaining pregnancy by stimulating uterine growth and opposing the action of factors involved in myometrial contraction. Progesterone is produced by the ovaries, placenta, and adrenal glands. Progesterone is used as a medication in combination usually with estrogens, in hormone therapy for menopausal symptoms, in contraception, the pill, combination with estrogen, to prevent miscarriages, to treat different gynecological conditions. It is my pleasure to introduce the first our speaker, Professor Giancarlo Renzo from Perugia, Italy, and the topic of his presentation will be progesterone, history, facts, and artifacts in pregnancy maintenance. Professor Di Renzo is professor and director of the Department of Obstetrics and Gynecology in Perugia, founder of International School of Perinatal and Reproductive Medicine in Florence. He is a full professor of the Department of First State University in Moscow. He held position of General Secretary of FIGO. He is a founder and editor of Journal of Maternal Fetal Medicine and an editor of Chinese Journal in English. Professor Di Renzo is honorary member of Royal College and ECOC. He is Doctor Honoris Causa at 16 universities. His scientific comprised production of papers and books. He organized international congresses. He has been invited speaker in hundreds of national and international congresses. Please, Dr. Carlo Di Renzo.
I hope that you hear my greetings to Professor Schenker, which I thank you very much for the nice introduction, and to Professor Genazzani, who is the master of organization of this kind of meeting. And I'm so happy to speak about the history, the facts and artifacts of progesterone, also because there is a very recent paper I published in open access. You can download free from the best practice and research of a British medical journal, just came out 1 month ago, which is dealing with a similar subject. So let me go and explain you what is progesterone, okay? Because sometimes to obstetrician gynecologists, they don't know how is the real potential of this hormone. First, we should say no obstetrician gynecologist was involved in the discovery of progesterone. Progesterone was discovered by an anatomist and by a chemist, okay? The physiology of corpus luteum was a study developed by the anatomy department at the University of Rochester, and George Corner was a student of Will Allen, okay, a chemistry student working in pathology, and they published in 1929 a pivotal classic replacement experiment in which they extract material from the corpus luteum of pigs and they administered to pregnant rabbits which had been ovarectomized. And the result was a change in endometrium consistent with pregnancy maintenance. And so they say corpus luteum should be something that is capable to sustain pregnancy. Then, after the discovery of this hormone, which was called in different way, lutesterone and so on, progestin, 4 people sit around a table during a dinner, during the endocrinology meeting in London, and then they publish a small paper. You see that the most important paper in the world are very, very short, and they give the nomenclature of the corpus luteum hormone, calling progesterone, which, and there are 4 people, and the 3 of them got the Nobel Prize, by the way. We're 1935. Progesterone is progestational ketone steroids, as you can see here, a steroid molecule with a ketone body attached. Very simple, okay? And the 2 others who isolate the hormone got a Nobel Prize for chemistry. So progesterone gets 4 Nobel Prize. 4 Nobel Prize for the discovery of this hormone. Never happened in the history of all the Nobel Prizes, and I think in the history of medicine. But the most smart person was the one to be able to synthesize progesterone from a plant, because in the past progesterone was extracted by the ovaries of the pig, and you need 50,000 pigs to get 1 gram of progesterone. 50,000 pigs' ovaries to get 1 gram. You can imagine the costs were unbelievably high. Progesterone was used just in very few cases. Russell Marker was a very interesting chemist, German chemist. He discovered this special, very simple reaction to extract progesterone from the wild yam, which is very popular in Mexico. He bought a lot of fields in Mexico to build up a company, and he made a lot of money with progesterone. But unfortunately, his life, anecdotal, didn't went well because, you know, Mexican tried to steal the money to him, killed him, and for a few years, the formula disappeared until others in Germany were able, a few years later, to develop again the same formula and to make the progesterone available. But at that time, progesterone was still a hormone with some difficulties for let's say, introduction in the clinical practice, because the bioavailability of hormone was limited only to intramuscular route. Because unfortunately, progesterone itself was not easily absorbable by gastrointestinal tract. And you know that there are nowadays many ways to make progesterone, not only from the wild yam, but also from soya. But be careful, because the compound that derived from soya is not so pure as the one that is derived from the wild yam. And of course, the fact that progesterone was not so easily available, it prompted many chemists to develop the synthetic compounds with progesterone action. And this was called progestogens or progestins. And the synthetic analogs were mainly developed for contraceptive agents, because in around the 50s, if you remember, Genazzani and many other people after Pincus tried to develop the contraceptive pill, and they are very good estrogen available, bioavailable by gastrointestinal absorption, and progesterone only by intramuscular route. So they put together many chemists to develop new progestogens that will be helpful. But you should know that progestogens don't have all the action of natural progesterone. And it was only when 50 years later, it was developed a micronization of progesterone. So the capability of progesterone to be suspended in oil and packaged in gelatin capsule and put in actual dissolution, that the absorption was available by intestinal route. This is a very series of milestones that characterize the story of progesterone. You can see that after the 40s, in which was obtained the progesterone by natural precursors, Georgiana Seager-Jones was, after the Second World War, the one that started to use progesterone, for instance, for luteal phase deficiency, for avoiding fertility, and for many other usage. And she was a really pioneer afterward with Chapo to understand the mechanism of progesterone. And in the early 80s, there was development of micronized progesterone. But I would say that progesterone is living a new era, because many of the activity of progesterone have been discovered in the last only 10, 15 years, especially those depending from the route of administration. We can give progesterone in many ways, as you can know, but in many ways progesterone has different metabolism and metabolites. For instance, if I give a bi-oral natural progesterone route, the metabolites that they have in gut, intestinal wall, and liver make progesterone metabolites acting on the central nervous system, on the GABA system, as antimitotic agent, as tocolytic, as an anti-inflammatory drug, and so on. If, however, I try to do this mechanism for other synthetic progesterone, I obtain the same effect. So the advantage or the disadvantage of other way of route depend not only from the metabolites, but also of course, the compliant patient. Progesterone injection, which have a vehicle which is mainly oily, very painful, sometimes give a local infection, abscesses, skin allergy, and so on. So the further development was to find another easy way to vehicle progesterone in the women body, and was the intuition that the mucosa of the vagina and the cervix can absorb progesterone, the micronized progesterone. And either you give as suppositories, jelly, or other formulation, then you see that in 3 or 4 hours, all the receptors of the genital area are completely blocked. And the pharmacodynamics of progesterone comprise many actions that depending from the metabolites and depending from the way of administration. So it's a rather complicated hormone. It has anti-androgenic effect, anti-mineralocorticoid effect, tranquilizer effect. I'm sure that some of these effects we can play very well according to personalize to our patient, according to the way we can give. For instance, if we want to have mainly an effect on the genital tract, I should prefer the vaginal route. If I want a more general effect with also tranquilizing effects, I should give for oral route and so on. And be careful when we use progestins, because some of them have similar effect, at least in some organs. Some don't have the same effect at all. And this is something that we have not to confound, because we should be aware how potentially powerful is progesterone alone and how less powerful are the different progestins. For instance, just speaking about pregnancy, this is a very striking experiment. Progesterone in the first 3 line is inhibiting contraction that you see elicited by oxytocin, or strips of myometrium. If I go 3 lines down, I see 17-hydroxyprogesterone, which is a progestin. Not only does not inhibit the contraction, but sometimes it increases the contraction. So this means there's no effect on the myometrium. And this is very important to take into consideration. So just to summarize the route of administration, we can give progesterone almost in many part of our body. May have a systemic effect, non-systemic effect. We may attain good concentration, for instance, in breast tissue. If I give by transdermal route, I can give intramuscular to obtain more blood concentration, and I can give a vaginal route in which I have minimal or even no discomfort, and I avoid the first hepatic passage. It probably is the safest way to administer progesterone. Now, briefly, what are the facts about progesterone pregnancy maintenance? You know that one of the key problems of a pregnancy is to understand that pregnancy is the entrance of incompatible tissue in the maternal immune system, okay? So the conceptus is a sort of allograft, as we define, in which there should be a modification of the immunologic system of the mother to tolerate this sort of transplant. Either there are few cells at the beginning, like the blastocyst, which implants in the uterus, and later on, the fetus completely formed. Now, in order to do this, progesterone has been demonstrated in vitro and also in vivo to have a lot of immunological properties which are in favor of this effect. So progesterone is not probably so important in the first 2-3 hours after conception, but is crucially important at implantation and to prepare the uterus for implantation and to make a difference in the immune system of the mother. We should go from a cell-mediated responses mainly to humoral-mediated response, because we have a balance between our lymphocyte Th1 and Th2, which of course have different action. The Th1 are mainly cell-mediated response through macrophage, interferon, and so on, and Th2 mainly are devoted through some interleukin to produce antibodies. okay, through beta cell, plasmatic cell, and so on. Now, progesterone mediate this balance, okay, mediate in favor of Th2, because Th2 has much more anti-inflammatory action, which is important for maintaining pregnancy, and has no pro-inflammatory action, which is dreadful for pregnancy. Implantation cannot come well, and we may have miscarriage. So in order to see how progesterone works, you know, progesterone is elicited and maintained by the production of ACG from the trophoblast, and progesterone has some action which regulate prostaglandin production, decreasing prostaglandin production, improving the angiogenesis, which is essential after implantation, and having a facilitation of immune tolerance acting through different enzymatic activities which maintain and suppress macrophage and natural killer cells. These actions are mainly due to a product, intermediary product by progesterone, interaction through the progesterone receptors with the lymphocyte, which is the progesterone PIBF inhibiting factor, which has a potent anti-abortive effect. You see, PIBF induce increased production of Th2 cytokines, and PIBF express, for instance, this animal model, the changes that are needed, which have been also very recently shown by the group of Stephenson in Chicago on the implantation window for modifying some of the enzymatic activity of the endometrium, which is transforming so-called decidual. And you can see that in order to demonstrate this true, if you give an anti-progesterone agent like RU4086, you completely block, or an antibodies for anti-BBF, you completely block this action. So we come back with a schema which is very simple, simplify the problem. Progesterone acting through IVF favor the implantation and normally progressing pregnancy. If you block BIVF either with mifepristone or with antibodies against the PIBF, you have miscarriages. And this is what we have described also as a schema that put progesterone as the key hormone to maintain pregnancy maintenance. But the action of progesterone is not going only at beginning with implantation. As I say, natural progesterone has a potent anti-inhibitory activity of myometrial contraction. So progesterone fights or equilibrates estrogen, prostaglandin during all the of pregnancy, and maintains a quiescence of the uterus until the beginning and triggering of labor. So in summarizing, progesterone and the bioequivalent progesterone, which is the micronized progesterone, have a modulation of maternal immune responses, improves uterine placenta circulation through the nitric oxide system, antagonist prostaglandin and CRH action, which are probably related to stress and the prostaglandin increase of inflammatory, eventually substrate, reduce uterine contractility, suppress immunoplacenta inflammatory response. So the problem of progesterone is quite clear nowadays. But I would like to conclude with this little paragraph. What means apples and pears with progesterone? Unfortunately, you know that nowadays, to establish that one drug or any action we do is useful, really useful in clinical trials, we have several potential ways, but ideas, case report, and case series are not sufficient to enter in the arena of clinical action. And we need at least cohort studies, or the best of the best, which is a randomized controlled double-blind studies, okay? And from these randomized controlled double-blind studies, sometimes we get up systematic review and the so-called meta-analysis. But this is the little trick that we have to be very careful, because when I put together the meta-analysis, and Professor Genazzani is sure to speak about this shortly, we can have, as you can see here, studies which meet the criteria of any randomized control trial. The green light means that everyone is good. So when you have the result of this study, what you're saying about putting together many studies is meaningful. And you can start from many publications in order to arrive at a very good study which give a meaningful insight and maybe change our clinical activity. But when we have a weaker design, as in this study, you see a lot of reds, which means that the criteria are not met, we cannot get the conclusion even though our statistic looks so promising. Because in this case, we mix apples and pears. They are similar, progesterone, progestins, but they are not the same. And we try to make this kind of, Frankenstein-like data in which we want to have some result, we want to arrive to some conclusion, but at the end, if you look carefully, you go inside, you see that the criteria that we choose is to give a supplementation in one way of some kind of progesterone, in another way, and so on. So again, we mix apples and pears. And these are some examples that are very typical of progesterone utilization and clinical utilization. One of these is this issue. So I want to go sharply to my conclusion, only addressing the safety concern. Progesterone and progestin are not the same thing. Progesterone has been cleared up by any safety concern, by many studies done also in the very recent year. But some progestogens have not been cleared up by safety concern, like for instance, the progesterone, which has been now put in some warning for the database produced by the Israeli Maccabi Health Service, which has shown a link between the use of dihydrogesterone in early pregnancy and congenital heart disease. Okay, these are warnings, but we have to be clear again. We are not using the same drugs. We cannot mix apple and pear. So in conclusion, I would say long history to progesterone, many facts which have been strongly demonstrated, especially in the last 10 years, with a strong biological plausibility to support exogenous natural progesterone use for the management and the correction of many disease of pregnancy. Optimal dose, route administration, duration should be determined and personalized. We have a possibility to use progesterone in many ways to the best of our patient, but be sure that progesterone, natural progesterone, is a very safe molecule. And now there is a level 1 of evidence that can be used without any effects on the neonatal outcome, health outcome, and the cost effectiveness is very good. With this, I thank you again for your attention, and I hope that I'm open for any question. And I would say that progesterone is a very nice molecule, and I think that we will discover more in the future because it's so interesting molecule and one of the most ancient in our world, as you know. Thank you.
Professor Di Renzo, thank you very much for your telling us the history of this important progesterone that we are dealing with nearly closely now to be to 100 years. I think we still will discuss, as we are discussing it, some years of its effectiveness, and especially the effectiveness in prevention of threatened abortion or spontaneous abortion. And we will have many questions for sure from the public, discuss this after all presentation. And now I ask our second speaker, Professor Andrea Genazzani. Professor Andrea Genazzani is Professor of Obstetrics and Gynecology and Director of departments of universities in 3 sites, mainly in Italy, Cagliari, Modena, and Pisa. In 1994, he received honoris causa of the University of Wrocław in Poland. In 2005, in the University of Constanța in Romania. In 2007, University of Bucharest. 2011, Dr. Honoris Causa, University of Athens. Professor Genazzani is a founder and editor of Journal of Gynecological Endocrinology. Secretary of our International Academy of Human Reproduction, and Professor Genazzani will give comments on the PRISM trial, Progesterone for Prevention of Miscarriages. Please, Professor Genazzani.
Thank you. Thank you very much, Professor Schenker. Thank you, dear friends. It's my pleasure today to introduce you an interview of Professor Arri Coomarasamy on progesterone for the prevention of miscarriage, the PRISM trial, evidence and recommendation, who rise after the recent publication on the American Journal of Obstetrics and Gynecology. Who is Arri Coomarasamy? He is the director of the Thomas National Center for Miscarriage Research at University of Birmingham, University of Warwick, and Imperial College of London. He is the director of the WHO Collaborative Center for Global Women Health at University of Birmingham. And Professor Coomarasamy is the founding trustee of AMALife, the United Kingdom registered charity with a global mission of reducing maternal deaths in low-income countries. And you will see now that interview that you have done, which is present on YouTube, easily accessible by everybody on YouTube. Please go on and enjoy.
Hello, I'm delighted to be able to share the PRISM study findings with you. Our clinical trial explored the effects of progesterone treatment to prevent miscarriages in women with early pregnancy bleeding. More than 4,000 patients from across 48 hospitals in the UK took part in this trial. The intervention was vaginal micronized progesterone utrogestan 400 milligrams taken twice daily from when the bleeding started to until 16 weeks of pregnancy. What did we find? The live birth rate in the progesterone group was 75% compared with 72% in the placebo group. We had 54 extra babies in the progesterone group. Now, we had a pre-specified hypothesis that progesterone effects may be better in women with increasing numbers of previous miscarriages. The reason is that an increasing number of previous miscarriages is linked to an increasing risk of a euploid miscarriage. It is such euploid miscarriages that could be rescued by a treatment like progesterone. Was there a subgroup effect according to the number of previous miscarriages? If there were no previous miscarriages, progesterone treatment was not associated with any increase in live births. However, in women who had 1 or 2 previous miscarriages, if they are bleeding in the current pregnancy, progesterone was associated with a 4% increase in live birth. And in women with 3 or more previous miscarriages and current pregnancy bleeding, there was a 15% increase in live birth. No safety concerns were identified from progesterone treatment. The question is, of course, what should we do in clinical practice? Our recommendation is that if a patient with no previous miscarriages bleeds in early pregnancy, we will recommend supportive care. However, if a patient with 1 or more previous miscarriages bleeds in early pregnancy, we would recommend vaginal progesterone treatment with utrogestan 400 milligrams twice daily from presentation to 16 weeks of pregnancy, in addition to supportive care. This trial was only possible because of the commitment of hundreds of research nurses across the UK and thousands of selfless women who took part in this trial. Thank you.
I thank all of you for looking at this beautiful presentation. And I think that the data are absolutely convincing. And this stress also the importance of a large effort in the population. In studies related to miscarriage, as you can easily understand, there are so many reasons for the miscarriage that it's very, very difficult to provide a positive results with any possible drugs and treatment. Then I thank all of you for the attention to that meeting, and I would like to make all my compliments to Arri Coomarasamy and to all the staff who have made possible this beautiful study. Thank you very much.
Thank you, Andrea. And we shall go to the last speaker of the present webinar, Professor Martin Birkhaeuser, His topic will be why progesterone for menopause therapy. Martin is professor and chairman emeritus, Division of Gynecological Endocrinology and Reproductive Medicine, University Bern in Switzerland. Graduate Medicine, Basel University. His research interest is on women's health, menopause, research on postmenopausal osteoporosis. He was awarded for research on polycystic ovarian syndrome. He is also a member of the board of our International Academy of Human Reproduction, and he is a treasurer of Society of Gynecological Endocrinology. Martin, please.
Thank you, Professor Schenker, for this very kind introduction, and welcome to everybody still present today in this webinar. I'm happy to present today another chapter, not a chapter of fertility, but a chapter of menopause. As you see, the title is Progesterone, the Nature's Choice for Pregnancy of the whole symposium, and my title is Why Progesterone for Menopause Hormone Therapy. I have no conflicts of interest to declare for this subject. You see the silhouette of the city of Bern. Let us look first at natural and synthetic progesterones. As you heard at the beginning, the synthesis and the discovery has been a long and complicated story. I start with some glimpse at the molecules we are interested in. Progesterone is at the left, it is C21 steroid, testosterone is a C19, and estrogens are C18 steroids. As you see, they are completely different in many points from the synthetic estrogens shown here below, and especially in some of them, this group has been added, changing metabolism completely. So we should never confound a natural sexual steroid with a synthetic one. The natural progesterone has no estrogenic activity. It has anti-mineralocorticoid activity and a weak anti-androgenic activity. It is a bioidentical hormone. There are no bioidentical alternatives to progesterone. Also, the production of progestins, including dihydrogesterone, is usually based on plants. Progestins are not natural and, of course, even less bioidentical. They are fully synthetic. The mechanism of action of progestogens starts with the genomic actions linked to two receptors, and then we have a non-genomic effects, and these occur after binding to specific membrane receptors. The binding of progesterones to PRA and PRB causes a dimerization, as you know well, and the interaction with the progesterone responsive element at the DNA. In general, the receptor B is activating and the receptor A is inhibitory. The inhibitory receptor may suppress not only the transcriptory activity of progesterone B, but also that of the estrogen receptor, glucocorticoid receptor, and melanocorticoid receptors. So we have interactions between the activity of progesterone and other steroids. In most tissues, the synthesis of the receptor A and receptor B is estrogen dependent, whereas progesterones may suppress that of ER. Let us have a look at some metabolites. We have two inactive metabolites, here and here. And then we have active metabolites. This one has a progesterogenic activity, this one a mineralocorticoid activity. And then we have two with a sedative activity. And this may be important in some side effects. Some women suffering, as you know well, from sleepiness or drowsiness during the day. These receptors, sedative receptors, are not expressed in the same way in all women. There are big individual differences. You have to have a glimpse at the hormonal activities of progesterones. Here you have the natural progesterone. You see the activities already mentioned. Here we have the dihydrogesterone. It has the same activity here, a weak anti-malarial activity here, but no other partial activities. And then we have the synthetic progestins used in menopause, MPA here, with a small androgenic activity on the glucocorticoid activity, and Dionagest uses on contrast for menopause 2. And the special case is tibolone, the active metabolites, having a strong androgenic activity. A special case 2 are northisterone and levonorgestrel having androgenic activity too. So you can use these 3 synthetic substances in women having a predisposition for osteoporosis. In this case, they might be better than other progestins. Let us have a look at the retroprogesterone dydrogesterone. Many people think that is nearly identical to progesterone, but that is not the case. The steric configuration is completely different. Progesterone is flat and retroprogesterone is bent downwards between the rings B and C, therefore the name retro. As a consequence, there is no central effect. We have no influence psyche, on temperature, on mood, on hot flushes, sleep, vigilance, and gonadotropin release. And of course, the metabolism differs completely because of this different structure. So you should never compound the two. And already mentioned before by the first speaker, we might have some clinical consequences in pregnancy too from these effects. In menopause, mainly 2 ways of administration have been recommended. The oral administration at the beginning has been badly absorbed. The problem has been solved by the micronization of progesterone in smaller particles, minus than 10. That creates a greater surface and as a consequence, a better resorption. And then we had several studies trying to use transdermal progesterone, but we have to remember that progesterone has a very low polarity. That means it goes very badly to the skin. As an example, if you administer about 40 milligrams progesterone per day, the serum levels are only 1 or less nanogram per milliliter. To compare, in the normal luteal phase, reach levels of 5 to 15 nanograms per milliliter. We'll see the clinical consequence later. What about endometrial protection? Here you see the classical data from the Women's Health Initiative, proving that endometrium is protected if you combine estrogen with a progestin. In that case, we had MPA. So it looks as progestins are safe in general. But then we come to progesterone, and there we see that the transformation dose is very, very high, 4,200, compared to values between 5 and 120 for the synthetic progestins. So progesterone is a special case, and we have to use high dosages. The other aspect we learned from this slide, the ovulation inhibition dose is high too, so progesterone cannot be used for contraception. But nevertheless, we know that if you use progesterone for endometrium protection up to 5 years, that based on a systematic literature review on micronized progesterone for endometrial protection, oral micronized progesterone provides endometrial protection if applied sequentially for 12 to 14 days per month at 200 milligrams per day for up to 5 years. These values are secured by several studies. What about the longer use of progesterone in postmenopausal women? There the data are weak. We have just the EPIC trial, and if you look at the red framed part of the slide, only 26 women have been included in this study with micronized progesterone. And from these 26 women, we have the impression, or we might get the impression, that progesterone is not safe. However, we have to comment this data. The plausibility of an increased risk of endometrial cancer associated with micronized progesterone is really weak. As said before, only 26 cases. Then we know that the data are in contradiction with the PEPI study, a very solid older study. This study used MPA and micronized progesterone at the dosage we use still today. In PEPI, after 3 years, there were no significant differences in the occurrence of normal biopsy specimens in women given micronized progesterone versus placebo or versus MPA. So the PEPI trial, progesterone itself was as efficient as MPA. And then we know too that in the EPIC study, the compliance with oral progesterone was low. What about transdermal progesterone? Is there an endometrial protection? The biggest study available today on the endometrial safety with transdermal preparations included 54 women, but only 41 have been evaluated. Here is the dose that is used. The result have been that 32% of the women evaluated had proliferative changes, proving that the gestational protection was weak. Of these 12 women, 10 cases had a proliferation and 2 cases had hyperplasia. So transdermal progesterone is not safe in women after menopause for endometrial protection. Here the conclusion of the international panel. What do we know today about this endometrial protection by progesterone? We know that oral MPA provides endometrial protection if applied sequentially for 12 to 14 days per month at 200 milligrams per day for up to 5 years. Then this group says vaginal MPA may provide endometrial protection if applied sequentially for 10 days per month at 4% or every day at 100 micrograms per day for up to 3 to 5 years. But in postmenopause, that has not been approved. It is off-label, and I think it shouldn't be used. And then they state transdermal MPA does not provide endometrial protection. Here you see what is approved, what is not approved. The oral scheme in these dosages is approved. For perimenopausal treatment, the treatment of dysfunctional bleeding is not approved. The vaginal treatment is approved for assisted reproduction, as you see here, and in later pregnancy, until now, it's not approved. The transdermal way cannot be recommended for systemic treatment. So what is interesting in my lecture is the first point, yes, in postmenopause, to compensate the estrogenic effect, it is approved. This is an interesting slide, an old slide, but a good one. It shows the rate of hyperplasia of 12 months of high-dose estrogen and the effect of progesterone. As you see, it takes at least 13 days, or better 2 weeks, to reach a stable situation. If you think of the weak transformation activity of progesterone, I think we should, at least if you go to more than 5 years of treatment, continue for more than these 13 days. I would recommend a continuous combined treatment with micronized progesterone in these special cases. What about the breast cancer risk? Again, first, the data from the Nurses' Health Study, the classical, one. Estrogens alone in this study have been safe up to 15 years. No increase of breast cancer. A small increase has been shown only after more than 20 years. So that are the data from the Nurses' Health Study. What about the Women's Health Initiative? In this special study, in a special population, we have no increase. We have even a hint to a decrease of breast cancer risk if you use estrogens alone, in this case, conjugated equine estrogens. So estrogens alone, up to 20 years, are not negative. What happens if you add a progesterone? Here again, the data from 13 years, and now the combination with MPA. There, the balance changes at 7 years. So that hints to the point that the addition of at least MPA might decrease the neutral or protective effect of estrogen alone. Interesting enough, we have another study, the Dutch study, a European study, and there it has been safe combination of E2 and norgestrone acetate for 16 years. So progesterones are not all the same in their efficiency on breast. Then we have the French cohort, the E3N study. You see the numbers included at the follow-up duration. The results in function of the progesterone's use show that the risk does not increase if you combine estradiol and the progesterone itself, the micronized progesterone. The risk does not increase with estradiol and dydrogesterone. And In contrast, if you use estradiol and synthetic progestins, the risk increases, and this is significant. That has been the first report at the beginning. And this first report has been supported by the completely different study from Cortina Duverger, but it shows exactly the same. Both are French, by the way. If you add natural progesterone to estrogens, you have no increase, and the synthetic progestins have an increase. A strange thing is the difference between these two kinds of progesterone derivatives, but we have to stress that this group is very small, so I would rely on this high increase in this study. We have to repeat that later. What about the cardiovascular risk? We know that estrogens alone, again the Women's Health Initiative, have no increase of the risk for myocardial infarction. If you add a progestin, it might be different. What do we know about progesterone, natural progesterone itself? We have the data, excellent data from the monkeys, from Adams and his group. If you have a control group monkeys, the plaque area increases with time. If these monkeys are substituted by estradiol, you have no increase. And if you add progesterone, the situation is absolutely identical. So progesterone does not neutralize the beneficial effect of estrogens. That has been shown in other studies too, that the monkey study where you perfuse acetylcholine to get the dilatation of an artery. If you use conjugated estrogens, then you have an improvement, a bigger dilatation. If you add MPA or in a cyclical or in a continuous way, this beneficial effect is highly compromised. So again, MPA is not the best substance to be used, at least in this experiment. We have data in postmenopausal women too, exactly the same principle as acetylcholine to get the dilatation. Here you have placebo, estradiol alone, and estradiol with progesterone. Both are significantly better than placebo. The difference between these two, E2 alone and E2 plus progesterone, is not significant. So again, progesterone is not counteracting the beneficial effect of estradiol. And the last study by Giuseppe Rosano in patients where he tested if myocardial ischemia could be exercise-induced. The women had all a previous myocardial infarction. Baseline value here, E2 alone, delays already the beginning of the ischemia. MPA has here no negative effect, but no beneficial effect. And here you have progesterone, where there is a further delay of the appearance of the ischemic symptoms. So again, progesterone is, at least in these experiments, more positive than other progestins. What do we know about stroke? If you use transdermal estradiol in the study of Canonica, stroke risk is not increased. If you add to transdermal estradiol progesterone, you have no increase. If you add pregnant derivatives, you have no increase. If you have norpregnant derivatives or testosterone derivatives, you have an increase. For testosterone derivatives, the situation is better than for the norpregnants. Mainly in this study, normegestrol acetate. VTE risk in the ESTher study, is there a difference between migrans progesterone and norpregnants or pregnans? If you use transdermal E2 alone, you have no increase up to a certain dosage. If you use migrans progesterone in addition to E2, no increase. Pregnans, in this study, you see the substances used here, no increase, but norpregnans, a highly significant increase. Again, progestins and progesterones are not all equal. Interesting point, what about fracture risk? Of course, you remember the data from the Women's Health Initiative. The total risk of fracture has been significantly decreased in the combined group and in the C alone group. So that is secure and the data are safe. There is one older study looking at different progestins and progesterone and their effect on bone. In this study, BMD, the delta BMD has been measured out 2 years of duration of the treatment. With placebo, of course, a decrease, MPA, a decrease. Remember the depot preparations. Progesterone, small decrease, but not significantly different from zero. NETA, an increase because of estrogenic and androgenic partial activities. If you add, estradiol alone, of course, positive. If you add CEE and MPA, the effect is a bit less, not significantly, but the trend than E2 alone. But in contrast, if you add NETA, you have a further increase of bone mineral density. At bone 2, progenitors are not equal. For progesterone, unfortunately, we have no data in combination with E2 in the postmenopause, but you have data from bone gain in transgender women's therapy in cis women. The principle is here. We have an increase of bone formation by activating a specific receptor. And in these special patients, we have a significantly greater spine BMD gain with EPT, that means estrogen and progesterone, than with estrogen treatment alone. And the difference is highly significant. I think such a study should be repeated in the postmenopause. What can we say if we summarize the effect on bone? All these first 3 points you know well, I don't repeat it. Just to mention, until today, there are no data showing that micronized progesterone might add an additional benefit in postmenopausal women to the administration of estrogens alone, but we have the data from the cis trans persons where it's positive. I come to the conclusions. Most important point, there is no class effect. Some people don't remind that enough, especially in the agencies. Take-home messages: micronized progesterone is safe for individual protection if given up to 5 years. Micronized progesterone might be safe for endometrial protection of more than 5 years if given orally in a continuous way, about 200 more milligram per day, depending on the person, has to be confirmed. Numerous studies strongly suggest that it is the progesterone component of MTHT that is more significant in any increase in breast cancer risk than the estrogens. And we know that micronized progesterone does not increase cell proliferation in breast tissue in postmenopausal women compared with synthetic MPA. We know that micronized progesterone and dihydrogesterone do not increase breast cancer risk in studies up to 5 years. And we know too that micronized progesterone does not neutralize the beneficial effect of estrogens alone on myocardial infarction and stroke. Conclusion: for MHT, transdermal natural E2 in combination with oral micronized progesterone is a safe choice, particularly in the elderly. Thank you for your attention.
So thank you very much for your deep information, and especially for the practical recommendation of the use of progesterone. So after the speakers, let us start to ask questions, and we will have a discussion.
Joseph, if you agree, I can pick up some of the question that I see in the question and answer box, and I answer. And then I leave it to Martin and Professor Genazzani to answer to their specific question.
Okay.
There is of course, there is a metabolization of progesterone by the liver, but the vaginal progesterone absorption and the concentration in blood are very, very low, 10 times lower. So practically it's negligible, the number of metabolites which may affect eventually the brain compared to the ones that are coming from a gastrointestinal route or by muscular route. Mm-hmm. This was one question. The second was related to the effect of progesterone post-endometrial tuberculosis. There is no direct effect of progesterone, but there is some report about medroxyprogesterone in tuberculosis, in which there will be some report of exacerbation. But as I say, to speak about progesterone, progestins, and Professor Martin has also underlined the differences, we have to be very cautious. So I think at the moment there is no evidence that progesterone is affecting the tuberculosis, which in some countries, of course, is still a major problem. The combination of dihydrogesterone and micronized progesterone in RT, I don't see any reason to do this because, of course, you can use one over the other, but as I say, there are some safety concerns now on dihydrogesterone. And I think, therefore, that it is safer, unless these safety concerns are cleared up, to use only micronized progesterone. And the vaginal or oral route, of course, some women may prefer the oral route because they think that to put a capsule in the vagina is a little bit scary. Sometimes even if you have spotting during pregnancy because they think that they can exacerbate spotting. I would say that if you start with the appropriate dosage of progesterone by oral route, for instance, 400 to 600 milligram, when there is a threatened miscarriage, you stop bleeding in 1 to 2 days. So you can continue then with a vaginal route. Vice versa, if you want to continue with the oral route, there is not too much different. There are a few studies which make more or less an equivalent status, although you may need a little bit more of progesterone by oral route to obtain the same effect in the vaginal compartment, but you should be aware of some potential effects on the, tone, on the sleep, and so on, because, of course, of the interference with the GABAergic system. And for maintaining pregnancy, I think that it has been quite clear from the video of Professor Coomarasamy that it's been suggested to continue progesterone at least until 16 weeks if you have a threatened abortion or recurrent miscarriage. But I would like to say that if you have a short cervix of a previous preterm birth or a reason why there is a risk of preterm birth, you should continue up to 36 weeks. And of course, which progesterone to give, I already said. The final, there is a little question about the PRISM study. Yes, the overall result of PRISM study were not significant, of course, but if you go and look at the second evaluation, which has been done in patients with a previous miscarriage, with one previous miscarriage, they became statistically significant. This is why the reason. We, many of us, which participate in different progesterone trials and headed by Professor Coomarasamy, wrote the paper of the American Journal, which has been just mentioned by Professor Genazzani, in which make a meta-analysis of the similar study with a very big consistency, showing that if we give progesterone in a previous, in a treated miscarriage with a patient with a previous miscarriage, there is a merit, statistically merit to give progesterone. But the dosage should be very high, 800 milligrams a day. And this is something that is not being taken into consideration by many. I would like to stress the fact that dosage is also important, not only vaginal route, but the dosage. I will stop here for the first question. Maybe now Professor Genazzani and Professor Birkhaeuser, they have their own questions.
I'm looking at my questions. Yes, there has been a comment saying that data of digestion due to the breast cancer are from observational studies. I know that is not strong, but we have to take the best evidence. Unfortunately, it is the best evidence. But we should need, in the future, I think, a randomized controlled trial. My question is, who will pay for that? I fear that we will never have it. So we have to rely on what we have. But I agree, it is not very strong. So how do we counsel about this data? We can only say from preclinical data, it looks quite good, but we cannot say more. Would you agree, Andrea?
Yes, I agree with you.
About dihydrogesterone 5 milligrams in continuous combination, is it safe for endometrial and postmenopausal women? I would say usually yes, but there are some women needing more, and that you can guess, or by ultrasound, or if there are some bleedings appearing, of course, you're forced to investigate it. But some women need more. I would say a very low percentage. Then the bioidentical progesterone, well, that is a difficult question because I think it comes from the United States. And there we have products on the market that are not safe. In Europe, it's different. You cannot sell everything you want over the counter. But you have to pay attention. I would rely on an approved, FDA approved or EMEA approved preparation only. One question is leaving menopause and going to young women, stating that would it be useful in young women with secondary central amenorrhea and thrombophilia mutation to treat osteoporosis. I think we have no data on that. I cannot remember I have seen a study in young women with this special mutation. I'm sorry, I cannot answer. Can somebody else answer? Andrea, do you remember anything about this question?
No, I would like to add a response. We had Sebastian Mirkin who asked about the Replenish study, and I would like to confirm that the Replenish study showed that 100 milligram progesterone per vagina in postmenopausal women combined with 1 milligram estradiol. In Replenish study, it was oral administration and of progesterone and oral administration of estradiol, and they have found a positive effect on endometrium without any periplastic risk.
Yeah,
I think that.
But the problem is here they're speaking of young women.
Yes, yes, absolutely. I think that the total question rising, they clearly indicate that there is a concern, there is a general request about what to use. And I would like to reconfirm what Giancarlo also was showing, that progesterone administration in early pregnancy with miscarriage risk, these have given some positive results showing that the amount of 800 milligram per day can give a consistent protection in women who had more than one miscarriage. And I would like also to go back to that other vision, because, you know, progesterone is the hormone that in nature has been chosen during pregnancy to protect the pregnancy, and has been chosen during fertile life to protect endometrium against hyperplasia. It's also clear that when we see when we start from that observation, the use of progesterone is also very safe in postmenopausal women, even for a long time. Certainly, the clinical data show also that dydrogesterone can be used orally and can have similar results to progesterone. And also all the studies, either on the breast cancer risk as well on the cardiovascular risk, they don't have shown any difference between dydrogesterone and progesterone, whilst difference has been provided that other kind of progestogen, they probably for the different origin of the molecule, they bring some either risk in breast cancer area as well risk in cardiovascular system. Then for safety and efficacy, we have to go to progesterone or dydrogesterone in postmenopause. And I think this is something of very important as we are changing now our behavior and our perception of the risk of menopause hormone therapy. Menopause hormone therapy with transdermal or transcutaneous estrogen will then avoid the first pass in the liver, and vaginal progesterone. And vaginal progesterone can be considered the safest possible treatment, or with oral dydrogesterone instead of vaginal progesterone. I would like also to stress the fact that oral progesterone given can easily be transformed in the liver in allopregnanolone. And allopregnanolone, not in everybody, but in sensitive individual, gives some central effects, and then is sleeping, and then is hypnotic, and so on. And then it's not possible to be used to everybody, not for the safety, but also because this is a physiological effect of the molecule. Then it's better to go per vaginum. You can go per vaginum, and the absorption is absolutely beautiful. And the way of reaching the general body is the same that in nature God have decided, from the ovary to the general periphery without crossing the liver. This is my general comment. I think that this is a natural choice, and probably we have not to change it for others.
Oh. I've seen a question that disappeared now, but interesting, about tibolone and breast. That is a complicated story. We know that the relapses in tibolone-treated patient having had a breast cancer is higher. And we know that in healthy women, there is no increased risk. So Herbert Kohl published some data showing that the activity of the TPRO metabolites at the breast is not the same in breast cancer cells and in normal cells, what might explain the difference between the two studies. But I think the chapter is not closed completely. Even if we have clinical data from other sources, not from the big studies, showing that the increase should not be clinically relevant. So I would say up to 5 years, TPRO is not a problem.
Martin, can I answer very briefly to 3 other new questions that I've seen on my side? One is progesterone and meningioma. I don't know if everybody has news, but progesterone has never been associated with meningioma, but progestogens have been associated in late, after 50 years old in patients with some meningioma. And this was a warning raised with some progestogen, not with a natural progesterone. Secondly is the progesterone and COVID. And now we can use everything to try to make a treatment for COVID. I don't think at the moment we have any evidence, although progesterone stops some cytokine surge for sure. But you know, one of the things that COVID may do, since there are AC2 receptor also in endometrium, may interfere with fertility. And we don't know anything about it, but it's an interesting area we can study for the next future. And the last one is how long to give progesterone, recurrent miscarriage, and pregnancy maintenance. I would say that progesterone, as the European Society of Human Reproduction has stated, should be started in luteal phase to be useful for prevention of recurrent miscarriage. Secondly, as I said, the dosage should be at least 800 milligrams up to 20 weeks. And eventually, if the patient has also a high risk factor for preterm birth, should be continued.
I would like also to add a response to the request that if in a woman of 46 years who had hysterectomized, who had that 44 myocardial infarction, then we can use vaginal estradiol. Vaginal estrogen, absolutely yes. Vaginal estrogen, they don't rise the circulating estrogen. It doesn't have any effect on vascular level. And even so, it has been published by Finnish group, Professor Mikkola, that only estrogen also given per vaginum in normal population, they reduce the cardiovascular risk. And also, I would like to answer to the question from Honzan, 1 milligram estradiol and 5 milligram progesterone in continuous combination partner. It is safe for endometrial and postmenopausal women. Absolutely, yes. Long time studies have shown that it's absolutely safe treatment. Okay, thank you, just for the moment.
That's an interesting question, in part for you, Andrea. If you stop estradiol and you continue progesterone, do you have a sedative effect, and should you do it after menopause for symptomatic women? I think I never tried it, but why not?
Yes, also they have no data, but I think it's not conceivable that we have any specific risk by that way. And okay, then the question, a nice question from Vanya Schwich. She asked, how soon after vaginal application is progesterone absorbed and patient can shower or can swim? Yes, the patient can shower and can swim, but you have, I think it should be better if you administer vaginal progesterone at the night time, if it is only once a day, for example, after menopause, and because during pregnancy, I don't suggest too much to swim. They can certainly shower at any time. If you administer twice a day, you have to conceive that during the night time, during the daytime, she can have some exit from the vagina, from the fluid originating from the progesterone administration.
Yeah. And then we have a question concerning bone from Bangladesh. We know estrogen increases the bone density, but does progesterone alone prevent bone loss? No, we have no data for that, unfortunately.
And then I would like to go to the answer to Kanwal 9 Sing Sing. You know, she mentioned, I don't know never if they are named male or female, but he or she mentioned that in Asian women, they are not keen for vaginal insertion. You know, for vaginal insertion, also not only Asian women, but most of the women they don't like. For that reason, we were looking for an oral progesterone. And for that reason, oral dydrogesterone can be used by those who don't like the vaginal administration.
And the next question is a difficult one. Is dose of 1 milligram oral estrogen equal to 25 patches and equal to one measure of estrogen concentration 0.06%? Well, if you go to Europe, the answer is not the same as in the States. And it depends on the organ you're looking at, because the activity is not in the same proportion at all organs and all tissues. And the Americans are for 1 milligrams most, and we are more for 2 milligrams, depending exactly on what we measure. Do you agree, Andrea?
Yes, I agree with you. I agree with you. And then this is a question from Shaikh Sinat Nashrin. And she asked, please let us know what progesterone need to be used in early stage of endometrial carcinoma and for how long. For endometrial carcinoma, you have to use a very strong progesterone. I think medroxyprogesterone acetate or also a progesterone have a very profound effect on the endometrium. And the treatment have to be prolonged until the disappearance of the endometrial carcinoma. You can use also local progesterone with Mirena, with who can directly increase the intrauterine content of levonorgestrel, but you have to use a very potent progesterone for that one, not only transvaginal or oral progesterone. There are no data on that aim. And we have Eitan Barnia. Hi, Eitan. Thank you to have you here on our webinar. He asked an opinion on Duaviv. You know, Duaviv is an association of basedoxifene and conjugated equinestrogen. This is for the women who want to have an menopause, a treatment of the menopause without a progesterone, but having also a safe effect on the endometrium. And then the association of basedoxifene to conjugated equinestrogen provide absolutely a good solution. Then I think there's no other question from my side.
Yeah. So if there are not other questions, on behalf of the Academy and our board, I would like to thank first to our speakers for their broad scientific presentation and for the hot discussion. I would also like to thank to the Congress organization this webinar and for the assisting with the technology connectivity. Special thanks to you, Mrs. Valentina Donnelly and David Genazzani at our support. Before ending today's session, it is my pleasure to invite you to join us in the 19th Congress of the International Academy of Human Reproduction, which will be organized in Jerusalem. As you know, we in Jerusalem are always optimistic. So we hope the scheduled days will be over the corona pandemics. Thank you very much again for taking part in the listening to the webinar and to the discussion.
Thank you. Thank you very much, Joseph. Thank you to all of you. And
Bye-bye. Thank you.
Bye-bye.
Thank you.